Dr. Shanavas as our lead faculty, and Dr. Jose as the mentor. And we have Dr. Krishna Priyan, who is a JR3, who is going to present the case. And we are having a child who has been normal till 5 years and then develop a slowly regression of his neurological status. So we'll be discussing this case this evening. So let me introduce Dr. Shanavas, but he doesn't require any introduction. For formality's sake, let me do my job. Dr. Shanavas is an alumni of Government Medical College, Toronto. He did his MBBS as well as post graduation from same college, and we had the fortune of having him as a faculty for as both associate professor as well as professor and HOD for several years, and we he was always it was always those good old memories, having sharing his academic thing with all of us, and his so I welcome Dr. Shanavas to lead this today's PG discussion. So Shanavas, please.
So, before going to that, to comment from Mohandas sir and Dr. AK.
Sir.
Oh, sorry.
So, good
Mohandas
evening.
sir.
Good evening, respected past state president Dr. Shuma Madam, Dr. Jose, teacher of teachers, Dr. Srinivasan sir, Dr. Purushottam sir, and program coordinator Dr. Mohandas sir, and today's teacher Dr. Shanavas, and all dear friends, students. So it is indeed a great pleasure to have one more session of our PG club. It's going very well and smoothly. And also, I think getting more and more attracted by both students and teachers. I hope that today we'll have very, very enthusiastic discussion because many teachers are here. I wish the program all the success. Thank you. Jai Hind, Jai IAP.
I request Mohandas sir to say a few words. Mohandas sir. I request Ojo sir to say a few words and as well as to introduce the case and the presenter.
I think Mohandas sir is there. Mohandas sir, please comment.
Mohandas sir.
Mohandas sir.
I was out for 1 minute. I think we can start the program. Andhageshwan sir spoke something?
Already. I already.
Okay. Okay. So today, Dr. Shanavas is the lead discussant. Dr. Shanavas was the coordinator last year and who did this program excellently well. So we will hear him as the discussant this time. And the team Alappuzha has arranged this week's program in a nice way. Dr. Srilata and her team. And Jose sir is the mentor. And a lot of senior faculty are here. And teachers also. Thank you. I think we will start the program.
Jose sir, with Jose sir to say a few words and also to introduce the case and the presenter.
I think we can start the program. Already, no nothing to introduce Dr. Shanavas sir as he was a great teacher and academician and very good friend of all of the PG club program. Last year, he done a wonderful job. And with this, we can go to directly to the academic phase. So over to Dr. Shanavas sir to start the program. Over to Shanavas sir.
So very good evening to all. So first of all, I express my sincere thanks and gratitude to IAP State Branch Dr. Mohan, lead by Mohan Das sir and Jose sir, and for giving me this opportunity to chair the session on a neurological case, that too a neurological case being discussed by a common pediatrician. So there will be some, there will be, this will be only a pediatrician point of view as far as a neurological case is being considered. Our Purushothaman sir is there to guide us further in this regard. He's also very much interested in neurology, and he's an all-rounder with very much interest in neurology and also localization of things like that. So I think we can directly go to the case to Dr. Krishna Priyan to start presentation. Please.
Okay.
You can try the lower down symbol for slideshow. The slideshow symbol in the lower down on the left. There, right. Okay, that one. Okay.
Okay, good evening all, respected teachers and colleagues. So starting, here's a case of neurological disease. So it's a 12-year-old girl child, 12-year-old girl Ardha, date of birth 9/11/2011, resident of Cherthala, Alappuzha. Informant is mother and reliable. Presenting complaints cough for 2 days, fever for 2 days, and multiple episodes of seizures. History of present illness: 12-year-old girl, non-case of neurological disorder on multiple anti-epileptic drugs, now presented with complaints of cough and fever since last 2 days. Cough was wet in nature, gradually progressive, with no diurnal or postural variation. Fever for 2 days, high grade, not associated with rigors and released with paracetamol. Child was initially taken to local hospital, given oral antibiotic and other supportive medications, and symptoms improved. No history of fast breathing, chest indrawing, no history of cyanosis, altered sensorium, inability to feed, no history of aspiration. There's a history of contact with upper respiratory tract infection present. On third day of illness, child had an episode of seizure in the form of frequent blinking of eyes, jerky movements of left upper limb, followed by stiffening of all 4 limbs, which lasting less than 1 minute. Postictal child was drowsy for around 15 minutes. Hence, child was brought to TDMC and had similar episodes on the way and while in casualty. Child got admitted in pediatric ICU and started on IV anti-epileptic drugs. But child continued to have multiple episodes of seizure with same semiologies, and all episodes were lasting less than 5 minutes. Further, IV anti-seizure medications were also added and then seizure controlled. Now child is febrile and seizure-free since past 2 days. No history of skipping of any anti-epileptic drugs, no history of skipping meals, no history of reduced sleep, no history of any trauma. After controlling seizure, according to mother, child's neurological status is same as before this event.
Okay, this is your presenting complaint.
Yes, sir.
So from this, what is your working diagnosis with regards to the respiratory problem?
The child, non-case of neurological disorder on anti-epileptic drugs. Now child had a two-day history of fever and cough after contact with an upper respiratory tract infection. Following this episode, child had an abnormal movements, abnormal seizure episodes, mostly a seizure just triggered by fever.
What about the respiratory diagnosis? What is your diagnosis?
Upper respiratory tract infection. As there was no danger signs or no.
Is it an ILA? You said it's a contact with the upper respiratory infection. Is it an ILA?
Yes, sir.
What is the definition of ILA?
Cough, fever, and myalgia.
So who all are your team. I have forgot your
Lubna is sir, Surya is sir,
Surya.
Vaishnavi sir.
Okay, so we will start with the Vaishnavi. What is ILA by definition? WHO. Not there, Vaishnavi.
Yes, sir. Sir, ILA is an acute respiratory infection associated with fever more than 100 degree Fahrenheit.
Okay,
and
100.4 degree Fahrenheit fever.
And any of the respiratory symptoms, including
Duration of symptoms
within the last 10 days.
10 days, and predominantly a respiratory or respiratory symptom of running nose, sore throat, like that. That will be the ILA. What is the SARI then? SARI. Lubina. What is SARI? So whenever you are everybody is very much interested in neurological, high-fi neurological phase, you will be sometimes you will be like that, like this in the examination. Will be asked simple questions. What is a SARI? Severe, the expansion.
Severe acute respiratory.
What is it?
When it with a similar case definition, when it requires hospitalization.
Okay, very good. The severity is sufficiently enough to needs hospitalization for us. So is it a SARI according to you, KP?
No, sir.
Okay. That's why then why was the patient hospitalized?
Because of seizure episodes.
Okay, due to seizure episodes. So is it an aspiration pneumonia? You are primarily dealing with neurological problem. Child is now come with a cough, difficulty in breathing, fever.
History-wise, there is no history of any aspiration, sir. And there is also no history-wise, no.
Will there be any history of aspiration? Will there be a history of aspiration?
No history of any lower respiratory tract infection.
Okay, you have discovered, you have described something that is rapid breathing, lower chest. Why should you apply that this one? Lower chest syndrome, rapid breathing, and danger signs.
To severity.
So is it applicable for your patient? ARI control program definition.
Yes.
Is it applied? What is the age of child, your child?
12-year-old.
So till what age it is applicable?
5.
What is the IMR cutoff for applying ILA? I mean, ARI, doctor.
5 years.
5 years, and what is the IMR, infant mortality rate cutoff for applying ARI control program? Anybody in your gang? This 40. This is mainly program for diagnosing in the community. But any patient with a respiratory problem, even asthma, you can apply these danger signs. You can these 6 or 8 danger signs you can apply, and you can assess the severity of respiratory infection by asking those things.
Okay.
Then, so you think it's an upper respiratory infection with it could be associated with what type of seizure?
So child initially had a jerky movements, focal seizure, then focal followed by generalized.
Okay, could be a myoclonic seizure plus a focal with generalized. Tail shows some bilateral eye blinking and also posturing. So could be okay. So far it is some neurological problem patient with some ILA influenza-like illness because of the upper respiratory syndrome. You should start how was the onset? It was an upper respiratory child. You didn't mention about upper respiratory infection. Subsequently cough like that. If it was if you have explained already like that, you will not ask any further question regarding ILA. Okay. So whether you should know the differentiate between ILA versus and aspiration pneumonia only, I asked so much question. Okay, you can go into the past history. Anybody, sir, anybody wants to ask any other question? Sir, Purushothaman sir.
Proceed.
Okay. Proceed.
Okay. Past history. Child was apparently normal around till 5 years of age. Then while in class, teacher noticed that child was having poor concentration in the form of inattention. The child also had insidious onset of unsteadiness while walking, and there was a need to hold the rails while climbing the stairs. No history of any falls while walking or difficulty in brushing, holding glass, drinking or eating. There's no history of any reduced speech, no history of abnormal movements. But later, as child developed frequent falls while playing, was evaluated with EEG and imaging. EEG was subnormal and started on single antiepileptic drug. But the frequency of falls increased over the next 3 to 4 months and child restrained from physical activities. 3 months later, child had a seizure episodes in the form of jerky movements of upper limbs. Child's scholastic performance was also becoming poor and she also started to withdraw socially. On subsequent months, mother noticed that child was not able to identify objects and persons but responded to call. There is a history of speaking difficulty initially noticed as decreased number of words and poor comprehension. Child was also not able to answer learned number and facts. Hence, they again went for evaluation in higher center. Imaging and seizure study was done and it became normal, but EEG was still abnormal. Dose of the current anti-seizure medication increased and one more drug was added. And mother was counseled regarding the possibility of further deterioration of motor and cognitive functions, advised follow-up and given guarded prognosis. Genetic study was also advised at that time, but was not done. In spite of hiking these anti-seizure medications, child continued to have further episodes of seizure. Further drugs were also added. At around 6 years of age, child had difficulty walking in ground, and by 6.5 years of age, child was even unable to stand without support. Then by 7 years of age, child had an episode of prolonged seizure, which was not responding to IV medication, for which she was mechanically ventilated for 3 weeks and treated with multiple IV antiepileptic drugs. Thereafter, child had massive decline in motor and cognitive function. Child could not get up by on her, and she was also not able to lift her neck from bed. But she was able to move her upper limb and lower limb. She could not speak any words or make any sounds. She lost her bowel and bladder control. And at that time, mother was not concerned about hearing. There is no history of any excited response to sounds, no history of any involuntary movements, no history of any repetitive hand-wringing movements, no history of drooping of eyelid or restriction of eye movements, no history of excessive sweating, no history of deviation of jaw, angle of mouth, and child was able to close eyes. There is history of difficulty in swallowing and feeding time was prolonged. There is no history of difficulty in moving head sideways, no history of deviation of tongue. Child was able to perceive touch, pain, cold and hot sensations according to mother. Child sleeps for around 8 hours at night with occasional awakening. In spite of this multiple AEDs, child continued to have seizure episodes. No history of any diurnal variations, no history of any hair abnormalities, no history of any skin hyperpigmentation, no history of abdominal distension or abdominal surgeries for hernia, no history of rapid increase or decrease in head size, no history of abnormal body or urine odor, no history of recurrent vomiting or hypoglycemia, no history of constipation, no history of yellowish discoloration of skin or eyes, no history of skeletal abnormalities, no history of teeth abnormalities, no history of oral thrush or recurrent infections, no history of contact with TB. Present status, child is bedridden. She is moving all 4 limbs but cannot hold anything in hand. There is no word output and cannot comprehend. Involuntary bowel and bladder movements present. No blood source or no skin rashes on multiple antiepileptic drugs.
Okay, can you just summarize the so far history? That is past history. That is.
Say 5.5-year-old girl who was developmentally normal till 5 years of age started to.
Was she able to? Was she attending school?
Yes, sir. She was going to school.
Okay.
Initially started to have poor scholastic performance, inattention in class, and also started to have unsteadiness in gait, which further increased. Later increased the frequency of falls. Then also she started to develop episodes of jerky movements of upper limb, followed then also with the different episodes of seizure with different semiologies, which was not responding with the single drugs. And later, child had an episode of seizure, prolonged seizure, which required mechanical ventilation for around 3 weeks, followed by which child had a massive deterioration of all the motor and cognitive function, which resulting losing in all the attained milestones. Thereafter, child was bedridden.
So according to The child was absolutely normal till 5.5 years.
Yes, sir.
The whole problem started after 5 years.
Yes, sir.
Okay. So according to you, from the history, what are the areas of brain affected?
Initially, as child, as cognition and inattention, gray matter is affected.
Okay. So how will you differentiate between it's a what first thing is this is whether it is a static disorder or a progressive disorder.
Yes, sir. It's a progressive disorder.
Okay. So you're saying it's a progressive disorder. That is number one. Number two is whether it is a when it was any fluctuation of course, or it is gradually progressing over time.
It's progressing or times are no episodic.
No episodic worsening in between.
Episodic
Except
worsening.
for the episode during seizure. Okay. So you think it is a gray matter disease. How will you differentiate between a gray matter or white matter disease?
Gray matter, dementia, seizure, and all results in gray matter. Then also psychological symptoms.
So number one is the cortex is mainly involved.
Cortex is mainly involved.
Intellectual deterioration.
Intellectual deterioration.
Seizures are poor scholastic. That will be the primary onset of symptom with the seizure. Seizure can occur in white matter disease also when it is very late.
Yes,
so
sir.
very early seizures. That two are the main important things. Then what are the other things in the history will have other than these two?
And also there can be a basal ganglia involvement resulting in abnormal movements.
So which type of disease, white matter or gray matter? Basal ganglia involvement.
Basal ganglia, gray matter.
So what can you tell on basal ganglia involved degenerative disease?
Wilson's disease can involve.
Wilson. Juvenile Parkinsonism, Huntington's chorea. So all these are diseases with that's a gray matter. These are the focus of nucleus deep in the brain. So those area cells can produce external. Okay, other things.
Other eye retinitis pigmentosa.
Okay,
so,
so you can both can have ophthalmic problem, visual problem. So white matter disease, what is the pathology?
White matter.
This is the pathology of eye problem.
Optic atrophy.
Optic atrophy. On the other hand, in the other one it is
retinitis pigmentosa.
These are retinal, anything retinal chorioretinal problems. So it could be RP. Which is the classical condition with the retinitis pigmentosa?
Okay. White matter disease. Gray matter condition.
Okay. The gray matter condition can have this one. Anything else? What are the other things?
Then this image electroretinogram and
okay. So
it will be abnormal in gray matter.
That is a investigation base. When you go to investigation, that will be two different groups of investigation. So then that's how you can differentiate. So what according to you, what type of disease is this one?
This is initially involving gray matter due to as cognition is affected.
Initially itself cognition could be gray matter. Subsequently could be anything, white matter also be affected. So what are the things will you consider as diagnostic possibility in this condition? As
child was having initially cognition and also episodes of all myoclonic, there's a possibility of firstly I will consider SSP.
Okay. SSP is an acute disease, so you can consider SSP is a diagnosis. So point you will be coming to the past history later only. Okay. In that case, we can. What are the manifestations of SSP?
SSP in grade 1. Initially, cognition
will initially you have scholastic backwardness with the
scholastic backwardness. Then by grade 2, seizures, then
okay, other things consider?
Other also as child is having progressive deterioration along with the myoclonic drugs, will consider other neurodegenerative disease like NCL.
So anything can be considered juvenile type.
Juvenile Gaucher's.
Juvenile types of GM1, GM2 gangliosidosis.
Type C Niemann
like that. You can have neurodegeneration genetically onset neurodegenerative condition can be considered. Okay. So coming to the so no history of reduced speech initially. You can tell here in this we have shown there is now speech is affected. Right?
Yes, sir.
Okay. Next slide. So next slide. Abnormal movement. Why should you ask?
Now is there any extrapyramidal involvement?
Okay, you can have abnormal movement mainly in the extrapyramidal. Okay, then. Okay, then Next slide. So there is speaking difficulty. Child was not able to answer. Learn. Okay. Then next. 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 So child was not controlled on even on multiple anti-epileptic drugs. Okay. Next. Able to move. Okay. Next. So I should you ask about exaggerated response to sounds.
Exaggerated startle as in Krabbe, Sandoff ties GM2 most common is GM2 gangliosidosis.
Okay, taste sacs. That's infantile taste sacs. When it is the juvenile, it comes usually.
Taste sacs.
It is not juvenile taste sacs is not associated, usually not associated with the hyperacusis. Then involvement you are already told. So why you ask about repetitive hand wringing movement?
Rett syndrome.
Why are you considering Rett syndrome here?
As it is a female child.
Okay, so it's a female child with a neural degeneration. Always think of what is the inheritance of Rett syndrome?
Autosomal dominant.
Autosomal dominant.
X-linked dominance.
Okay, so that's why this. Then drooping of eyelid and restriction of eye movement. Why should I ask?
Cranial nerve.
Okay, which disease cranial nerve involvement can occur? Eye manifestation can occur.
Restriction.
Eye manifestation.
Gaze palsy is in.
Okay, so gaze suitable
vertical gaze palsy is in Niemann-Pick and.
So vertical Niemann-Pick disease can have vertical gaze palsy and also
horizontal gaze palsy in Gaucher's canal.
Gaucher's canal. Okay. Both can. Okay. Okay. Why should I ask about excessive sweating?
Autonomic involvement.
Okay. So what are the other eye manifestation will you ask in the case? You can come when you examine. We'll ask those questions. Okay. Next. Deviation of jaw may be due to facial nerve. Okay. Swallow and feeding time is increased. Okay. Okay. Deviation of tongue. No history of deviation of tongue. Why should I ask? History, will you get a history of deviation of tongue?
No, not.
Okay. That's an examination you should look for 12th canine examination. Okay, next. Child was there pain, cold. So how can a child moribund like this stage can appreciate cold, hot sensation, but pain you can, okay. Child may able to, you can ask. How will you ask pain sensation for this child?
Injections are during IV injections.
So he
child used to cry.
Okay, that pain, okay, of course, that can also be, but cold and hot sensation, I don't think. Okay, I should consider some experts for it. Okay, child sleep 8 hours at night. Okay, that's good. So, in spite of multiple AED, child continued for seizure episodes. Okay, so can you finish? You have finished your history? Just so. Diurnal variation. Why should I ask for diurnal variation?
Segava or Dopa responsive.
Okay. If you are progressive, if you consider progressive, sir, Segava, Dopa sensitive disease can be worked. Okay. Then hair abnormality. So I should ask.
Menge's disease or cocaine syndrome.
Okay. What is the hair changes in Menge's kingy hair disease?
Menge's this trichorexis of the trichorexis nodosa.
It will be hyperpigmented and also normal shape. Then microscopy will show trichorexis nodosa. Pileotorte. So inheritance of Menge's kingy hair.
X-linked recessive.
X-linked recessive. What is your sex of your patient? What is the age group of Menge? What is the maximum age of? So usually they before 3 or 4 years usually. So for you asking, you are giving clues enough material to ask questions. What is a chromosome genetic abnormality of
ATP 7.
Yeah.
7A.
Okay, and then B, what is it?
Wilson's.
Okay. So like that, you may ask questions when you are giving this type of Excellent. Okay. What are the skin diseases with hyperpigmentation?
Adrenal leukodystrophy.
Okay, leukodystrophy, sir. We can consider leukodystrophy, especially late onset leukodystrophy can manifest on this age group. Abdominal distension, ideas.
MPS can have abdominal.
Okay, again,
MPS.
MPS and all you can't consider because manifestations are sufficiently early. So if you can consider some neurodegenerative with hepatosplenic organomegaly, maybe a reason for abdominal distension. No history abdominal surgery and hernia. Again, usually they will manifest a bit early. 6 months onwards, they will manifest early. But mild form only when your patient is having severe disease, everything. Okay, okay. Then finish. Any more thing? A rapid increase or decrease in head size. So what are the conditions with the rapid head size? Rapid. So you can use better words. Rapid increase or
Any space occupying lesions resulting in progressive hydrocephalus, which can.
So space occupying lesion is not a good diagnosis. Since we are presenting with a neurodegenerative disease that's last.
Alexander Canavan.
Okay, you can consider those things. Even big Gaucher, I mean neuronal, not Gaucher. And like disease we can consider. Then abnormal body or urine order in case of IEM. Okay. Vomiting, hypoglycemia, history of constipation.
Hypothyroid.
Even in a potentially serious or progressive condition, you should consider cases that are potentially treatable. So that's a good question that you should ask and look and rule out hypothyroidism. Okay. So, just yellowish. Not at all. Okay. No history of yellowish discoloration skin and eye. Why?
Tyrosinemia, Wilson's, galactosemia.
Okay, tyrosinemia, Wilson, galactosemia. But there is a problem when you are answering. You are dealing with start with 5 years and it will be Wilson. You can definitely consider tyrosinemia, very young age group. Then no history of skeletal abnormality could be due to makeover surgery, sir.
MBS.
Okay. Teeth abnormality. Ask teeth abnormality.
Forage syndrome. Forage.
I also know that. Okay. So then no history of oral thrush recurrence. Why?
HIV.
Okay. So HIV, potentially infectious causes. We already. What are the infectious causes of neurodegeneration?
HIV, CMV.
CMV. CMV is not. Already you said SSP. Then
SSP. Then rubella.
Progressive rubella syndrome. Progressive rubella syndrome. Then nowadays it is neurobrucellosis. Never an entity. Brucella is also can produce occasionally. Progressive.
Jacobs decay.
That is not common, but for theoretical purposes we can answer. Okay. Then
history of contact with TB.
Okay, then. Okay. Oh. Okay. So Purushottam sir, anything?
Yeah, I was observing very good discussion. KP, as sir said, the first point, is it a regression? Definitely, it's a case of neuroregression. In that, maybe when you are presenting the developmental history, whether the development up to 5.5 years, whether totally normal or there can be a situation of a little lag early and later going downwards. The period from 5.5 to 2 years, the regression and surviving at 12 years, those decline pattern will be useful. So there is a regression happening over weeks or months or years and very long years. Because there are main category of conditions we consider. First category, of course, the neurodegenerative disorders, which we all consider different group of neurodegenerative disorders, neurometabolic situations and all. But there are other conditions, just like last Dr. Shanavas put it, infections. Out of these infections again, few infections, neurotuberculosis, a typical presentation can lead to the problems within weeks, maybe months, never years. Other entities which can last for very few weeks, like autoimmune encephalitis and all, somewhat subacute and acute. It will not be more than, there can be a presentation of autoimmune also like this. And if it is for years together,
there are few infections only. The number of infections comes down. SSP is one, progressive rubella encephalitis is a very rare situation. HIV is one. So those things, out of which SSP, I don't think it will be persisting this long duration of years. 5.5 to 12 years survival in an SSP is unknown. HIV also, I think that duration is the catch in that situation. So in any other conditions which will be presenting like this, sometimes rarely some vitamin and micronutrient deficiencies. There are situations where it need not be a micronutrient deficiency, but vitamins and micronutrients has got a therapeutic role directly or indirectly. Something like biotin, vitamin B12, especially in this case. So those nutrition deficiencies. And third thing is a poisoning and toxins. So that all those category of conditions for regression also need to be considered. Maybe you will be coming in the nutrition history and other part of the history. That's all, Shanavas. The next thing is epileptic encephalopathies. Epileptic encephalopathy sometimes, but it will be more of seizures and higher level. Motor deterioration to this extent may not be that much in a case of regression due to epileptic encephalopathies. So it seems to be something other than that. Okay, Shanavas, go ahead.
Okay, so by the way, what is epileptic encephalopathy by definition?
Syndrome.
That is syndrome, something else. Syndrome is epileptic syndrome is there, epileptic encephalopathy is there. Then developmental encephalopathy is there, developmental encephalopathy plus epileptic encephalopathy is there. These are the various terms that described in Nelson.
So syndromic
seizure with the EEG abnormalities, that this leads to this EEG will leads to encephalopathy, multiple seizure activity, electrical activity in the brain. That's the definition given in Nelson. Okay, proceed.
Severe cognitive impairments.
Okay.
Antenatal history. Second degree consanguineous marriage, married at the age of 28 years. There's no pre-pregnancy illness, no preconception folic acid taken, regular antenatal checkups, mother blood group B positive, weight gain during pregnancies, mother does not remember. Then antenatal first trimester, uneventful, folic acid taken 2 dose TT, dating scan normal, no history of any hyperemesis, fever, rash, radiation or spotting PV. Second trimester also iron cation taken, quickening at 5th month, USG normal, no history of GDM, hypertension, bleeding or leaking PV. Third trimester,
which is the
uneventful.
Which is the inborn of metabolism or disease that is present in the fetus that can produce problem to the mother. That you are not your DD is inborn error of metabolism. Which inborn error of metabolism can produce problem, that is in the form of some fatty acid oxidation defect can manifest. Then
The natal history, 38-week term, vaginal delivery, female child, 3 kg AGA, cried soon after birth.
Okay. What is the importance of this history?
There is no there is no resulting in static
events.
events.
If it is a onset is a young age group, you have to be a detailed natal history to rule out static and
static and fluid.
Okay.
Postnatal history, no history of NICU admission, breastfed within first hour, urine and meconium passed within 24 hours, no history of respiratory distress, jaundice, seizure or hypoglycemia. Discharged on postnatal day 3. After discharge, child was feeding well at birth and was gaining weight adequately.
Okay.
Developmental history, all milestones were attained at appropriate age till 5.5 years of age. She was studying in first standard with good scholastic performance prior to the onset of illness. Gross motor pre-illness child was attaining all milestones appropriate to age. Then now child is having no head control.
So what was we are interested only what is the milestone at 5.5 years? What are the milestones? Right, tricycle, alternate feet going upstairs, not downstairs. 3 years, okay. What a child is able to climb downstairs?
4 years.
Alternate, okay, around 3.5, 4 years. Can be hop on 1 foot, alternate 4 years, okay. 5.5 years, child was, when the child has disease, child has 5.5 years. So you should have
5.5.
something, you should have some milestones about that also. So, okay, we'll consider it as more or less normal gross motor milestones. Okay. So, what are the ways a child can, degenerative disease can manifest? Sarah has already told, it could be a perfectly normal child like this, and then they'll develop neural degeneration. Then
delay and regression.
And so, for example, what are the things like development delay to start with? And so sometimes this stays second or will have hyperacusis from birth onwards, slight delay. Then even your neuromuscular disorders can also manifest as development delay and then progress. Okay. Then third thing is
the episodic regression.
Which is another condition with the episodic regression.
It's organic acid with following any events.
So mainly fatty acid oxidation defects are usually patient will be near normal when infection will develop, will go for hypoglycemia and seizure and all other problems. Then again recover like that. That's a fatty acid oxidation defect is a classical example of progressive worsening. Okay, then proceed.
Fine motor mother does not exactly remember the events.
Okay.
And now hands predominantly closed. Then social also. Child was by 5 years, child was able to dress and undress, was helping household tasks. Now child doesn't recognize mother. Then language also mother doesn't exactly remember, but she sings songs, poems, and was asked meaning of words. Now only child laughs.
So which is a regressive disorder where only language is affected?
Landau-Kleffner's.
What is it, Landau-Kleffner?
Isolated language.
Delay due to some of the epilepsies, some of the seizure activity that is occurring in the motor area, motor speech area, and that will produce epileptic. Okay. What is a condition where social milestones are being affected?
Autism spectrum.
ASD, usually it is not a true regression, but usually some of them will have good speech, then subsequently it will also lose. So that's okay. What about isolated motor regression?
This myelopathies can have compressive or non-compressive myelopathies. Then acute element Duchenne muscular dystrophies.
Okay, muscular myopathies and muscular is not myopathy, muscular dystrophies and also spinal cord abnormalities in the form of ICSO, spinal cord tumors can go on progressively. Like, then you can have okay, lead poisoning can also produce the organs. Okay,
then vision normal in pre-illness state, and currently child doesn't follow objects or show any response to light. Hearing alert to sound.
Okay, so now also patient is alert to sound.
Yes.
Or at 5 years. You're saying this is what 5 years or now?
No, this is current status.
Alert to sound.
Child says to sound.
Okay. We can believe whatever you are saying. You can't say anything. Okay.
Then immunization history, immunized for age. No history of any AEFI, BCG scar present. No optional vaccines taken.
What is the importance of immunization history for you?
Any optional vaccines are child is a case of chronic neurological disease. There is increased chance of respiratory infections. So optional vaccines can.
Which one? Be specific. You go on tackling so many things.
PCV, influenza, and
okay, PCV, influenza. These are two things that ideally influenza is the one that can produce precipitate. PCV, of course, can produce problem. Then what about you told me about measles. So you should tell. You can tell once again if patient was immunized against measles vaccination. As you can highlight that point. So that's the point against measles SSP. So patient doesn't have anything, but also immunized against. Then
diet history. Child was exclusively breastfed till 6 months of age. Complementary feeding started with ragi at 6 months. Child currently on semi-solid foods, including vegetables and fruits. Not on any dietary restrictions. No history of any pica.
What is the importance of pica for you?
Lead poisoning is lead toxicity.
So lead poisoning is very important. You should have. You should ask that question.
In calorie intake 1004 requirement 2060. There's a deficit of 646. And protein intake 39, requirement 31.8. That's an excess of 7.2.
Okay. Always the patient used to take food orally.
No, sir. Orally, sir. Orally. Not too feeding.
You said there is an increase in time consumption.
Yes, sir.
Okay.
Hello.
Proceed.
Family history.
Hello?
There is no history of any seizures, developmental delay,
Hello.
or intellectual disability in family.
Okay. So they said we have so the consanguineous marriage is there. Okay. The 16-year-old child is normal, right?
Yes, sir. No.
What is the sex of the child?
Female child.
Both are female.
Both are female.
Okay.
Socioeconomic status.
Okay. Anything relevant?
Anything no, sir. They are registered in the Niramaya scheme and they are getting.
So what is Niramaya scheme?
Health insurance for around 1 lakh they can get available for an year.
So whatever they are spending, they will get. So why they are not receiving? The other pension is saying they are getting pension. Okay.
Then coming to general examinations.
KP, in the nutrition history, when you mentioned about the nutrition history, a little bit odd it looks. Protein index is 39 and expect is 32 and extra protein intake. I would like to know whether there is a feeding problem in the earlier part. How much time it takes for a feeding session?
Around 30
by
minutes.
2 feeds only or a feeding problem is there?
No. They are not 2 feeding, sir. The feeding takes around 30 minutes per session.
So, and whenever there is a problem of a feeding, an excess of intake protein a bit unusual. In this case, very important to say about the other like fibers and other micronutrient source and also in the nutrition history. In the history part, you mentioned about the balance problem or frequent falling. A little bit of elaboration on the frequent falling is needed. Frequent falling can be due to cerebellar problem or a spasticity. In this case, at the beginning when you talk, I thought there was a cerebellar problem because in the initial categorization of I said white matter, gray matter thing, of course, many points are there for the gray matter, but there is a classical combination of a white matter is the limb spasticity and gait problems, and there can be optic neuritis as a reason for blindness, and optic atrophy as a reason for blindness, and white matter stiffness and spasticity, and there can be cerebellar involvement, that combination.
Yes.
So you need to clarify the point of the gait problems. Okay. And in the overall course, if there is an episodic thing, Shanavas was episodic indicate either due to stress, fever and all. Two possibilities. One thing definitely the metabolic part. The second one is the mitochondrial disorders also.
Yes.
So those things, definite relation with the stress and fever with the short duration of decline, then again coming back to. So that pattern of the status is important in this case. Okay, go ahead.
General examination. Child was awake, lying supine on bed with shoulders adducted, elbows partially flexed, right hip and knee extended, left hip externally rotated, and knee flexed, both angles plantar flexed. Heart rate 90 beats per minute regular, normal volume and character, all peripheral pulses were well palpable. Respiratory rate 26 per minute, saturation was 96 in room air, BP 104/70 in right arm supine position. And child was afebrile, mild pallor was present, there was no icterus, clubbing, cyanosis, lymphadenopathy, or no presacral or lymphedema, or any no other edema.
Okay, one more thing about the posture, a little more we are interested because what is the pattern of the long tract motor, extrapyramidal, the combination, the position description is more important because there can be a possibility of various combination. Okay, white matter, pyramidal, extrapyramidal, and deformity development and all. A little bit of a explanation on that point was needed. And you said about the possibility you consider the extrapyramidal also. So how to differentiate a pyramidal or extrapyramidal combination? What happens at sleep? During the sleep, what is the stiffness?
Spasticity is present, sir. Present in sleep.
Collaboration of any long duration, long tract situation like CP or neurodegeneration, because there can be secondary orthopedic involvement, complications and all. Okay, leading on to a change in the attitude and posture of the limbs. Okay, according to you, it doesn't seem to be scissoring or crossing over. The hip is externally rotated and all. So that is the point there, a little bit odd. Externally rotated at the hip, a bit unusual if both pyramidal or extrapyramidal, both are less likely to have a hip externally rotated. Okay.
Okay, sir.
Shanavas, somebody?
Yes, sir, yes, sir.
Okay, proceed.
Okay, so KP, so what are
Yes.
the neurodegenerative condition where there is pallor is a main feature?
Pallor, this Gaucher's disease and all, resulting in pancytopenia.
Okay. This
Then
Gaucher is
Niemann-Pick disease can also.
Okay. What about the edema?
GM1 gangliosidosis.
Okay, can have lymphedema. It is not a fitting edema. Can have occasionally. Okay. So this condition you can look for when you look for. Icterus we have already discussed. Okay. Then
head appears
One
small.
point, KP, pallor, always think of the rarer possibility of a lead poisoning. So with the pallor, you need to mention micronutrient deficiency possibility or a poisoning, especially upon other evidence of a lead poisoning like lead,
Bertonian line.
other things. Just for the completion sake, it's a treatable entity sense. That's all.
Then head appears small, flat occiput. Hair color and texture normal. No alopecia. No facial dysmorphism. Eyes no corneal clouding, cataract, nystagmus, or squint or cave ring, fundus, optic atrophy present. No signs of retinitis pigmentosa, macular degeneration, or cherry red spot. Dental caries present. No gingivitis or halitosis. No neurocutaneous markers, hyperpigmented patches, or generalized hyperpigmentation.
so how will you differentiate between primary optic atrophy versus secondary optic atrophy?
Disc edema can be seen in
Disc edema.
Disc margins are margin.
Okay, so the appearance of the disc will be irregular and also dirty white, and the number of discs crossing the disc margin will be less compared to the other. These are the primary optic atrophy versus secondary optic atrophy, which we really get primary optic atrophy. You already said it's a white matter degeneration. Then you should look for chorioretinitis and chorioretinitis. You said RP, retinitis pigmentosa. Then what else? Eye. Cherry red spot.
Cherry red spot.
What are the conditions of neurodegeneration with cherry red spot?
GM1 gangliosidosis. Niemann-Pick can have
GM1, GM2 we can followed by GM2. Then
Niemann-Pick, Tay-Sachs.
Then okay, so many. GM2 is Tay-Sachs. Okay. So like that, so many conditions can have associated with cherry red spot. So you have to. There are so many eye findings that can be seen in case of other eye findings are also seen in case of nystagmus. All those you should look for. Okay. What about neurocutaneous markers? What is important to neurocutaneous markers for you? Especially
this angiokeratoma can have
Fabry. Okay, angiokeratoma can be seen in far brand. The other thing is, what is the condition? Can have. Then what about
mongoloid spots? Mongoloid spots
widespread mongolian spot can be seen in case of GM1 gangliosidosis. And any mucormycosis can have like conditions. Okay.
Here again, KP, rather than telling the head appears small, okay, just measure. So up to 5.5 years, the child was okay, means by that time, 95% of the head circumference achieved. So don't expect more. Still, better to mention as a measurement. That's important. And then the fundus and the other findings, better, I think it's at the end, not in the general examination.
Okay, sir.
There are a lot of findings, as Shanavas sir said. in the general examination. Fundus and RP macular degeneration all as a part of the neurological examination the later. That will be better. Okay.
Okay. Then chest, Harrison sulcus present, no abdominal protrusion or hernia, no spinal deformity, contractures of bilateral angles present, no involuntary movements noted, no signs of any neglect. SMR stage 3.
Stage 3. Okay.
There again the contractures. What is the status of the contractures? Okay.
Static contractions.
That's need to be completed next after the contract.
So you'll be telling all this again in the neurological examination, isn't it? The general examination you are saying.
Yes.
Otherwise, you should examine the hip also. That's important to examine hip.
Dislocations.
You can have hip dislocation also. You should look for when there is a child with severe hypertonia. You should look for. Okay. Then.
In anthropometry, weight 30 kg between 3rd to 10th centile, length 150 centimeter between 50 to 70 centile, BMA 13.3 less than 5th centiles undernourished, head circumference 49 centimeter at minus 2.5 standard deviation microcephaly.
Okay, so nothing more to add. So is there any change in definition of microcephaly, sir? Recently, there is a talk that again, microcephaly also, the standard deviation has come down to 2 standard deviations. Have you?
No, എനിക്കറിയില്ല കേട്ടില്ല അത് ഞാൻ
അത് പുതിയ OP guy, the new OP guy gives it like that, but we contacted Dr. PSN Menon and sir contacted the author who has written it and they will correct it.
Okay.
So it is still -3 only. -3 only.
Okay.
So it has been put forward by some of the students. That's why we are also in trouble.
Don't blindly follow these books only in the learnments on the PG level. But here, KP, when you measure the length, better to mention about the mid-parental and the parental pattern because there are some declines and neurological problems where tall stature is there, like homocystinuria. Okay. There seems to be, weight seems to be 3rd to 10th centile, length seems to be on the higher, a little for this child. So there you better mention the parental heights and is it suggestive of a morphanoid features because the few of the metabolic problems will have a taller stature. Okay.
Yes.
So also your patient is having some contractures and all. You should have at least segmental height or segmental length. Okay. You have taken segmental length only.
Yes, sir. Segmental length.
Then you should mention that only. It may not be very correct. Even then, in spite of that, there is already one sir has already mentioned 150 centimeter. That is 70th centile. With the height is with the weight is very much low.
Yes, sir.
Okay, so that's you should be very cautious when telling. If it is, okay. Proceed.
Examination of nervous system. Higher mental function, child was conscious, not able to assess orientation, well dressed. Cranial nerves, 1 not tested. 2nd, fundus, signs of optic atrophy present. 3, 4, 6. Extraocular movement, full in all directions. 5th, no deviation of jaw. Jaw jerk was exaggerated. Appreciate sensation. 7th, no deviation of angle of mouth. Nasolabial folds normal. 8, child was alert to sound. 9, 10, uvula moving normally.
Okay. And for all the postgraduates, when you are presenting a list of no, in a case like this, don't expect a unilateral pathology.
Yes.
So all the deviations, this point is mentioned to exclude the possibility of a hypoglossal or a facial or whatever. Actually, that's of no use. But there can be bilateral involvement. So what you need to mention is the possibility of a bilateral involvement. Deviation doesn't make any sense. Here also, you mentioned the history here also. That's better avoided.
Okay, sir.
One more point I wanted. Why do you say it's well dressed?
There's not neglected child like that.
It's a well kept child. That is better.
Okay. Yeah.
Proceed.
Turn heads to both sides, no deviation of tongue or any tongue fasciculations. Then motor system, bulk, upper limb, arm, both upper and lower limb appears bilaterally symmetrical. When tone spasticity is present in all four limbs, modified Ashok scale 2. So both right and left, both upper and lower limb tone is increased. Then power, upper limb, shoulder, elbow.
Spasticity or rigidity? What is the importance of looking for that?
Spasticity, pyramidal rigidity, extra pyramidal movement.
Okay, you should look. You can mention spastic type of hypotonia. I said.
Then power, upper limb, shoulder, elbow, and wrist more than 2, and lower limb 2 out of 5. Hip, knee, and ankle.
How will you check this shoulder power?
Yes, sir. Shoulder just against, not against. Child was able to lift
the shoulder just
the head
and so they are moving about, or
child was just moving, sir. She was definitely she was moving. This removing gravity, she was sideways. She was moving, but above gravity somewhat.
Both proximal and distal are same.
Yes, sir.
There is no difference. Okay.
Vertebral reflex normal, abdominal reflex normal, plantar bilateral extensor. Deep tendon reflex. Deep tendon reflex, upper limb reflex 2+, knee jet 3+, angle clonus present. 4+ angle.
Okay.
And release reflex, frontal lobe release reflex, glabellata present, momental press, grasp reflex present, and snout reflex also present. Sensory system, child withdraws with pain. Cerebellar signs, no nystagmus or no pendular nature. Skull microcephaly, spine no deformity, no spinal deformity.
Okay.
Other systems, respiratory system, upper respiratory tract normal, chest, Harrison sulcus was present.
Here again, you are going into trouble. Why I said you are going into trouble with the microcephaly part. See?
Yes.
From whatever you have told so far, child was normal up to 5.5 years, or all the measurements, everything. Okay. By
Yes,
5.5 years, the growth of the head is almost 90-95%. Okay.
Yes, sir.
And the definition of the microcephaly is more than 3.75 centimeters.
Yes, sir.
So in the next, the age of the child after 5.5 to 12 is 6.5 years.
6.5 years.
During that 6.5 years, do you think there can be a disparity of 3.75?
No,
So
sir.
you're finding it very difficult to explain all those things. Okay.
Okay, sir.
So what is the measurement now? Actual measurement is so important. So you're going, that you will be finding it very difficult to explain that.
Okay, sir. Then serious apex beat at fifth left intercostal space, medial to clavicular line, S1 S2 head normal, no murmur. GIT per abdomen soft, no distension, no hepatosplenomegaly.
Okay. Okay. Summarize.
12-year-old girl born out of third-degree consanguineous marriage with uneventful perinatal period and no significant family history, who was developmentally normal till 5.5 years of age, started to have neuroregression in the form of spasticity, followed by seizures with the cognitive decline and lost all milestones. On examination, GCS was 10, optic atrophy present, pseudobulbar palsy, and aphasia present, spastic quadriplegia, microcephaly. There was no dysmorphism or no organomegaly.
Okay. Okay. So the salient features are patient is till 5.5 years normal, then neuroregression, predominantly seizure and cognitive involvement. Along with that, there is a long track sign, some features in the form of weakness is also is there. Upgoing plantar, DTR is there. What about peripheral nerve? So you should look. Did you look for peripheral nerve thickness?
No. No.
Where will you get peripheral nerve thickness?
White matter. White matter
disease. Neurodegenerative disease. Okay. Where will you look for nerve thickening? Nerve thickness. Ulnar nerve.
Then
Can have occipital nerves, sural nerve. So all those we can look for thickness. And any conditions with nerve thickness? Neurodegenerative condition with
giant X. Giant X. Giant X.
What? Giant cell axonal neuropathy. I was not aware whether there is nerve thickening is present or not. It's a rough sum is a condition. Rough sum disease is a condition. Can have neurodegenerative condition. Other motor weakness with this can be HMS condition. Hereditary motor sensory neuropathies can present with nerve thickening. It's not. It is a pure motor disease, not a combined disease. Okay. So here, what about what do you think? What type of neurodegeneration here is according to you?
So both gray and white matter.
Both gray and white matter disease. Okay. What type of problem? Why do you say it's both gray and white matter? What are the diseases?
Because child has affected both cognition and also there is abnormal gait, tone and spasticity and gait tone abnormalities also there along with cognition and seizure.
Okay. So both can be accepted, sir. Prishadam, sir.
Yes, in the examination, you jaw jerk is important, and the pattern of the reflexes a little upper limb all reflexes is 2+ only, and angle jerk seems to be 3+.
Yes, sir.
And this you said it's a spasticity only. There can be a combination of during the examination is the situation where you need to think about a combination of pyramidal plus extrapyramidal. So is there an element of the rigidity plus spasticity? A bit difficult to say that. Anyway, when there is an angle jerk 3+, that rules out the possibility of an associated peripheral nerve involvement. Because in the case of white matter degeneration, there are two situations, with or without peripheral nerve involvement. So, if it is a peripheral nerve involvement, that means angle jerk will be absent, and sir said peripheral nerve thickening is to be checked for. In this case, angle jerk is 3+. Okay. Okay, go ahead.
Okay, what are the conditions you
even though there are white matter involvement, pyramidal signs, I think as the onset of the disease, it is predominantly gray matter. So we should consider differential diagnosis where the onset is with the gray matter involvement. In the terminal stage or the final stage, white matter also can be involved in such conditions.
Right.
Another thing is whether we should consider microcephaly because -2.5 standard deviation എന്നാണ് പറഞ്ഞിരിക്കുന്നത്. അപ്പൊ നമ്മൾ ഒറിജിനൽ ആ ഒരു ഡെഫിനിഷനിൽ പോവാണെങ്കിൽ മൈക്രോകെഫാലി എന്ന് പറഞ്ഞു സാർ പറഞ്ഞ പോലെ വെറുതെ ഒരു കൺഫ്യൂഷൻ ആക്കണോ എന്നുള്ളതാണ് ഈ കേസിൽ. I think we can take it as normal rather than it's on a lower side rather than a microcephaly.
Okay.
എല്ലാ മെഷർമെന്റ്സും കേപ്പി ലെങ്ത് ആയിക്കോട്ടെ ഹെഡ് സർക്കംഫറൻസ് ആയിക്കോട്ടെ ആക്ച്വലി മെഷർ ദ ഹെഡ് സർക്കംഫറൻസ് പാരന്റ്സ് ഓൾസോ.
Okay. Okay.
അപ്പോൾ ആ 3 കാര്യങ്ങൾ മെൻഷൻ ചെയ്യാൻ മറന്നുപോയി. ഹൈറ്റ് പറയുമ്പോൾ യു ഡിഡ്ന്റ് മെൻഷൻ അബൌട്ട് ദ father and mother height and mid-parental height, whatever be situation. Maybe you didn't do that because you thought it doesn't have much of significance. But whenever you are mentioning about this thing, always do that. Head circumference also automatically head circumference of the mother. Okay. Then this confusion may not be there. Okay.
Okay.
Especially when it is abnormal.
Okay.
So here the height, there is a disparity in height and weight. So definitely we should think of that. Again, neurodegeneration condition, you should, as sir said, you should consider homocystinuria as a degree of this condition. Okay, then what about okay, so sir has said that is importance of history. Mohandas sir told that should be onset. How is the onset? So cognition and intellectual deterioration at the onset along with the seizure. So anything, this long track signs, everything can occur in any condition. The vice versa also. A white matter degeneration, when it becomes very much advanced, there will be neurological seizures and also dementia. All those things can happen. So you should concentrate on that and tell your diagnosis.
So the last part, Dr. Mohandas point out for all the PGs, it's a very, very important, valid point. We may be getting a situation where we may not be able to categorize it into this or that, gray or white. In the case of cyanotic heart disease, it is a decrease for pulmonary or an increase pulmonary and all. So that sort of a dilemma happens. There are certain very important clues. Here is a situation where at the end there can be a combination. All of us know which way to around or which move to decide. So this is the point. At the onset, it was predominantly seizure, decline in the cognitive and all. So that is a point dependable. So at the end, white matter also came. So it must be primarily a gray matter disorder. So the onset part is definitely useful in the categorization. So that's a very useful point.
Okay, proceed. What is that?
Diagnose progressive neurological disorder, combined white plus gray matter, refractory seizure, microcephaly, optic atrophy, DQS less than norms, undernourished, immunized for age.
Okay, so all these are acceptable. Refractory seizures, everything is acceptable. Microcephaly, only thing is there is a value problem. There's a what do you want? Microcephaly or macrocephaly for your or normal circumference for your diagnosis and differential diagnosis?
Normal.
Okay, between because our side is till 5.5 years child is normal.
Yes.
So that indicates that patient has should have a normal head circumference. 95%. We said by 2 years, 90% of head circumference is over. Then by 5 years, 95. There is nothing more to add. So acquired microcephaly can occur. What are the condition?
Rett syndrome and HIV.
Okay. So both can have acquired microcephaly. Even then, it is not very much. Okay. So,
and few of these neurodegenerative disorders also, apart from the classical Rett, few of the neurodegenerative disorders with the seizure predominance and all, a little on the lower side of head circumference, even though it may not be fitting with the clear microcephaly. A head won't be growing further. So stagnation of the head growth is part of few of the neurodegenerative disorders where this condition also fits with. Okay, so head circumference is definitely very, very important.
Okay, draw your differential diagnosis.
Differential diagnosis.
Eh?
SSP.
Tell out. Tell
SS,
3 or 4 important differential diagnosis you entertain and tell what points for and against. Then we'll go for investigation management. So you can't say anything when we fit anything.
I will
and
consider
this and that.
Juvenile Gaucher, sir, but point against.
Okay, number one, your first diagnosis juvenile Gaucher.
So first diagnosis, I consider NCL. As there was a progressive
expand.
neuronal cerebral lipofuscinosis.
What type? How many types of NCL are there now? Latest tells how many types of NCL?
Infantile, late infantile, congenital,
14 types.
Juvenile.
14 types of genetic abnormalities associated with NCL. Today's yesterday only we got the new Nelson. 14 types. So which the clinical types? It's like infantile. Okay. So which one you consider?
Juvenile type.
Juvenile type. Okay. Late infantile. Okay. Childhood. That is early. That too. Juvenile and early juvenile. Okay. juvenile type you can consider. Okay, then first diagnosis, NCL, then
NCL, then SSP.
SSB.
SSP.
Tell, quick.
Then
2, 3. You should have your own diagnosis.
Juvenile Gaucher, sir, but juvenile Gaucher.
Okay, juvenile Gaucher.
Then Niemann-Pick
Gaucher
type
is not juvenile like that. Gaucher is type 1, type 2, type 3. Type 1 is Gaucher. Which one is adult Gaucher?
Type 3.
1 ana or ana? 1 ana, 3 ana? 1 ana, 2 ana?
3.
3 is the one that you should have. Type 3 is one which has got a neuronal plus organomechanic. Okay. So neural, pure neuronal is the one that you can apply, but that child will not survey. You can tell, you can explain. I am not silly. Okay, you should tell. Points for against. Okay, next. You should NCL. Number 2 is Gaucher. And then
SSP, NCL,
SSP.
NCL, Gaucher. Then Niemann-Pick.
Okay. Juvenile type and Niemann-Pick.
Type C, Niemann-Pick.
Okay, Niemann-Pick. That is type C. That's the type C we are concerned. Okay, then. Over.
No.
You want to consider some infection? No, infection you already considered. Okay, yes, tell 1, 2, 3 like that. First diagnosis?
NCL, first diagnosis NCL.
Okay, why do you consider NCL in the juvenile type?
At least it is a progressive loss of cognition, and there is progressive myoclonic tissue. Progressive loss of cognition and progressive myoclonic seizures along with blindness, progressive loss of vision. So first diagnosis.
Okay. So we can always can be there in case of what you have mentioned. He said. So what is the other name of this condition?
Of
juvenile type, early juvenile is called Batten Mayo. This is also there is called. There will be the old bread textbook shows there is a picture with the blind person working like that. Okay, so but this was rapid, usually bit laterally the motor manifestation bit more late. Okay, so you can this much duration you can account this condition. Okay, next is SSP.
SSP.
Okay, why do you consider SSP?
SSP, it is here also child have a behavior problem.
Okay, child was normal till 5 years. That is a point 4. Then
age of onset 5 years. Then initially started with the behavior.
Okay, age of onset is 50.
Then initially started with the poor scholastic performance and behavior problems.
Scholastic backwardness and the seizure, especially myoclonic type of seizure. That is usually very common. Then what are the points against?
There's no
how many stages are there? How many stages are there?
Stage 4 stages.
4 stages. What is the usual lifespan of SSP? What is the lifespan of this child after the onset of disease? Already 7 years.
Already 7 years.
Okay, 7 years bit more. Usually, especially when there is a rapid progression, this much life expectancy after the onset is less, but can have occasionally. So, what is the eye finding in the case of SSP?
SSP.
So, chorioretinitis. Usually, you will have chorioretinitis in the usually. Also, subsequently, when it become very much progress, the septic atrophy can also, secondary optic atrophy can also be manifest. So, you can tell like that. So, because I am not getting the chorioretinitis, because the cell is very much advanced stage. Okay, sir, what is your opinion, sir? Sir, Mohandas, sir?
SSP, yes, one point is usually the myoclonic seizures will be a little more typical, something falling backwards, a type of this thing will be. And motor will be a little later. Usually by that time, there's a backward falling type of a myoclonic also occur. This duration is a little unlikely. Definitely in the neuronal spheroid, the previous one, a little on the lower side head circumference is definitely arguing for the first possibility. Okay. SSP, of course, can't totally rule out, but the possibilities are on the lower side.
There a history of measles? I didn't hear that.
No history of measles.
No history of measles, fully vaccinated. That is, he has already pointed out.
Then that possibility is very, very unlikely. With this or other odd points also with long survival and all.
So what is the relation? KP, what is the relation between measles and SSP?
These complications are usually seen after 7 to 13 years later.
Okay, okay. So what age stage will have measles usually?
Yearly.
It's at a very early age, before 1 year or onset of measles is usually very early. And associated other viral infection. 2 viral infections occur simultaneously. Also, there is a high chance of SSP to develop. Okay. Next one, another third diagnosis was
Niemann-Pick.
Gaucher. You don't know
Gaucher.
Okay. Gaucher is usually type 3 is unlikely. Only Gaucher where there is organomegaly is not there is neuronal Gaucher. Okay. In this type 3 as usually will have hepatosplenomegaly. So that we can't consider Gaucher type 3 here because there's no. Okay. Then you said there is usually we can have vertical gaze abnormal, so what is called oculomotor apraxia can also be there. Okay. Spasticity ataxia, spasticity can also be there. It can be there. You said Niemann-Pick. C. Okay, again. What is the finding?
Against there is no gaze palsy, is no vertical gaze palsy.
Okay, they may not be there. Cerebral spot is the
not cerebral spots, not cerebral spots.
That is the point usually. It may not be there. It is only 10% up to 30 to 50% of patients only will have cerebral spot. Niemann-Pick. On the other hand, the other disease, it is more commonly seen. And it's not a point strictly against, but you can, if it is there, it is a point for Niemann-Pick disease. Okay. Anything else? Anything else you want to ask? Okay. Sir, any other diagnosis we should conduct?
No, I think these are the main possibilities. Out of which first
okay, then we can go for the
most likely first one.
Okay.
Lipofuscinosis, I think some retinal changes you expect. You got only
that can subsequently leads to optic atrophy.
That is one point.
And CL usually have so many retinal findings. It can subsequently. So Purushottam sir already told epileptic encephalopathy. Can you consider some form of epileptic encephalopathy?
Yes, epileptic.
So this is like this condition. We don't know whether it is an epileptic encephalopathy like condition. Only thing is by investigation we can tell. So either it is an epileptic encephalopathy or not.
But the problem is motor part this much and reflex and all those things are unlikely. And the other one, gray matter, the behavioral, emotional, intellectual deterioration, intractable seizures, all these things. But the motor part and spasticity, UMN signs and all are not much. So that is not top in the list.
Okay,
type of progression also is gradually child lost this higher functions. So that again is less likely in epileptic encephalopathy.
Okay, so what about investigation management? We can
investigations. We can do complete blood picture to look for pancytopenia and suspecting Gauchers.
What about what is a blood picture abnormalities that you can look for in a case of storage disease?
Vacuolated lymphocytes can be there.
In all cases of lipidosis, we can have vacuolated lymphocyte. Anemia can be there. When there is a Gaucher-like conditions, thrombocytopenia can be there. So all those can be there. Okay. Then
acanthocytes can be there. Neuroacanthosis.
Yeah. Where?
Neuroacanthocytosis.
Which condition can be neuroacanthocytes?
Beta
lipoproteinemia. What is the other name? Base and constricts. Beta lipoproteinemia. So beta lipoproteinemia, what are the other features? It's an ataxia predominant condition. So it cannot degenerate condition, but we will not consider that. Okay. If it is for discussion purpose, we can tell. Okay, then proceed. Other investigation.
Then ABG for any acidosis, metabolic acidosis. For
Okay. So are you considering any IEM? You didn't mention any IEM at all. So far.
no, no.
Then I are
Small
going
molecule,
for.
small molecule defect early onset.
Okay, so usually an early one, but small molecule defects are very early onset and usually very progressive unless you use some restriction of the material. Okay, then
And electrolytes, serum electrolytes, adrenoleukodystrophy.
Okay.
Then specific like bone marrow examination for Gaucher's.
Okay. So bone marrow, we can have bone marrow
crumbled
examination.
crumbled tissue paper.
Okay.
Then for Niemantic also vacuolated form cells.
Okay. Then
Then hair microscopy. No, that's not considered.
Yeah, no, consider.
Not considered. Then imaging.
Okay, before that enzymes we can do.
Enzymes.
So your diagnosis was initially in a cerebral lipofuscinosis. So you can have enzyme as in fibroblast blood or
fingerprint bodies.
Okay.
Then for white matter disease also enzyme assays can be.
Then you can go for neuroimaging, MRI.
MRI, NCL, we get cerebellar atrophy with periventricular hyperintensities, symmetrical hyperintensities.
Okay. The definite diagnosis? Definitive diagnosis?
Genetic.
Okay, molecular study. Okay, molecular genetic study.
KP, when you are presenting the investigations, it should be definitely based on your clinical, because in the investigation there are many things. Don't mention something which are totally irrelevant. And this case, like your mangy, skinky hair and all, you are not considering at all.
Yes.
So based on the clinical judgment only you need to tell. And out of which, first thing which can be done easily, the cheapest non-invasive first level investigations you need to mention, like your urine and blood. There can be some of the clues. You make use of the clues, just like Shanavas sir said, peripheral smear, that RBC changes. Okay. There are findings in the peripheral smear other than the RBCs also, like the WBCs count. There will be morphological changes in the lymphocytes, some of the neutrophil changes. So, if at all you are considering storage without an organomegaly. Okay.
Yes.
And if you think the combination of white matter plus peripheral nerve, NCV also need to be done. In this case, NCV is not needed because you don't consider peripheral. Okay. So like that, going upwards. So simplest one, then fundal changes. Maybe there can be some few of the ocular related studies like NCV, the P100 and that sort of things. That also may be done as a non-invasive simple test. Then only you go for the imaging also is important, because when you are considering Gaucher, hip is very important. So if you are considering Gaucher's, it's a typical one will be the hip involvement can be there. So hip also imaging is important. Definitely most important ones are the imaging, EEG and the enzyme and genetic test. Okay.
Yes.
Evoke potentials.
EEG should be a
visual evoked potentials.
That's right. That's the one thing I mentioned in the evoke, but I didn't get the electroretinogram evoke potential. Those things are all non-invasive. So the NCV part, EMG part, evoke potential, retinogram, all those things can be mentioned in the second level in the investigation. And there are few of the situations where urine examination, higher level urine examination also may be helpful. Okay. But not in this case. Okay.
Yes.
Okay. So how are we going to manage?
Is first
Imaging
is
ചെയ്തായിരുന്നോ കെപിന്റെ എന്തെങ്കിലും ചെയ്തുണ്ടോ EG or MRI ഉണ്ടോ
MRI ചെയ്തായിരുന്നു.
നോക്കായിരുന്നു കാണിക്കായിരുന്നു
ഫിലിം
ഫിലിം ഇല്ല
ഫിലിം ഇല്ല സാർ.
ഓ ഫിലിം വേണ്ടിയിരുന്നു നല്ല ഇൻട്രസ്റ്റിംഗ് ആവുമായിരുന്നു അത്.
Okay, what about the EEG?
EG.
Any other investigation is there? Okay.
Then serum ammonia lactate pyruvate. It's not.
ഒന്നുകൂടെ കാണിക്കോ EG5.
Normal sleep consisting of symmetric and synchronous sleep pattern. Sleep spindles and K-complex are not seen. There was frequent activation of high amplitude sharp waves and spikes predominantly from bilateral frontal regions and bilateral parieto-occipital regions, occurring synchronously and independently. Polymorphic high amplitude waves of 2 to 4 Hz in our frontal regions. Not definite periodicity.
Can you consider SSP in this case with the EEG?
No, sir.
That is a EEG abnormality you usually expect.
Spike and
okay, like spike, polyspike, and burst suppression can also be. Okay, so shall we go to management, sir? Anything else? Yeah.
Okay, if you're considering the SSP also, definitely by this time you'll get a typical EEG thing. That then CSF studies also. If you're considering in this case, it's not much. So it is a confirmatory test. Okay. Okay, go ahead.
In view of the consanguinity, we have to consider genetic cause rather than acquired, because there's a third degree consanguinity.
Third degree consanguinity.
Right. Any genetic studies done in this case?
No, sir.
Actually, we are missing that investigations, especially the MRI, because in all these cases, MRI and the MRI spectrometry, all those things are very important in the analysis and evaluation of the neurodegenerative disorders. That is missing. EEG, of course, useful, but the imaging is more important. Then, of course, genetic.
Yes.
Okay.
Okay.
Management is supportive, treating the complications like feeding difficulty, gastroesophageal reflux, and all.
So you should first assess the problems. 1, 2, 3, 4, 5, 6. What are the problems? Number one, the most important problem child is having is seizure. So seizure management.
Seizure management.
You should help you should get the help from the neurologist and optimize the anticonvulsant. And okay, so that's number one. That's first. Second one, is there any feeding problem?
Feeding problem.
Is there any feeding problem? And if there is a feeding problem, you manage. So yes, you said there is suitable palsy also is there. There is a high chance of feeding problem is there. But you are saying early there is an increased time for feeding only. So you can manage if it is like that, or you can go for a pig. Also you can go for. But then contracture. You said contraction. So you can have
Botox, botulinum
management. Orthotic devices can be. Then you can go for any nutritional problem. Malnutrition is there. Any micronutrient deficiency, anemia, and all other B complex deficiencies. Vitamins, they are very much prone to develop vitamins. Scurvy, you have seen patients in bedridden can go for scurvy. So all those problems should be. These are the basic management of pediatrician. You can't do anything more. Then you can go for any other spasticity reducing things if it is needed. So you can have tone reducing things. Then physiotherapy for chest and also for the neurological problem. Then what else? Your family support. They are having how is the family, their home, one more child is there, always repeated hospitalization. How can you help? So palliative, you should connect to palliative care. They should be connected to the palliative care. They should get their own hospital near to the home. There should be some form of management so that their life will be very easy. You have already told you are linked them to their pension and also Niramaya scheme.
Yes.
Okay, so those things you should be these are things you should be ready with all those things. Investigate you till your diagnosis is your presentation was okay. After that, the differential diagnosis when it comes, you didn't have not ready. You are said even though you told there is no ready diagnosis. So you should have 3-4 diagnoses, of which 4 whenever you come for examination, 2-3 diagnoses for which you should have points for and point against. Investigation, depending on the condition that sir has told. Only those conditions that you are considered, you should investigate. All sorts of investigation. Management also like that. As a pediatrician, what will you do? What are the helps you will obtain from other support staff? Okay, calcium, vitamin D3, you should be in the high in the list because patient is always in the not exposed in sunlight. Should be. Okay, sir.
Okay, very good. All the points are very valid points. So we are not neurologists and super specialists. We are the person directly responsible for the care of these children. So more important persons, we are not the super specialist. All those last points for the practical points. And the one very important point Shanavas sir already mentioned, optimization of the seizure management. That's a very relevant word here because in this case, multiple anti-epileptics are there can be a small mistake in the management. Some of the anticonvulsants may worsen the seizure. That point very important. Some of the anticonvulsants are not the ideal and that is responsible for the seizures. So we need to avoid that group altogether and go for the other. That is one thing. And a trial with a few of these micronutrients sometimes may work, like biotin, like high dose of the pyridoxal, the B12, folic acid. Some of these maybe 2-3 months of trial, not for a long duration. Few of them can work. Few of them, there are typical neurodegeneration digressions where these micronutrients are helpful. So there can be a trial. And the last part, very important, social management. The caregiver burden for the mothers and the life of the siblings. All those things, the examination, examiners as pediatricians will be much bothered. They'll be asking. It may not be for the all day. If it is a younger child and parents, in this case, the parents are older, they may not be going for another child. The Mohandas sir will be talking a genetic diagnosis and the counseling, the planning for the next baby are all important. Another situation is a slowly declining situation. There may be a little more of a life, especially intelligent child, emotionally child. You need to support that part also. Educational planning and all that sort of are all important social parts. So that is enough, Shanavas. And KP, you have done well.
Thank you, sir.
What does sir anything to add? Wanda sir.
As there is consanguinity that you could have highlighted, and in DD you could have given preference to autosomal recessive problems. That is one thing. And another thing is you could have mentioned the age of the parents, whether they have adopted permanent family planning measures or whether they would like to have further children. And if they would like to have further children, you would have emphasized the importance of genetic diagnosis. Otherwise, it is not that much important because this child already bedridden and we are not thinking that we can have anything to cure this condition. So always, as Shanavas sir mentioned, supportive care and preventing birth of another child with similar problem is of very much importance. Another thing is you have presented well, but many times Purushothaman sir and all were saying some mistakes like you should not say deviation and all. So if you are convinced about that, when you present after that, you would have made that change. I have noticed that you are repeating the same thing after that also. So that you could have avoided some more presence of mind and readiness to change certain points, maybe.
Okay, sir.
Okay. Well presented.
Okay, thanks.
Okay. Srila madam, you want to say some final comments and then we can find.
It was an academic feast actually, with Shanavas sir leading, and Purushothaman sir and Mohandas sir also keeping up the same pace. And I think KP, as you all told, he has done well. So that's what I would like to say.
Srinivasan sir ഉണ്ടെന്ന് തോന്നുന്നു ദാസയെ സാറിനെ ഇൻവൈറ്റ് ചെയ്തല്ലോ.
Sir was there, now it's not seen. That's why.
Yeah, very much there.
Sir.
When listening and learning also. So of course, it's a very interesting case, and of course, you have brought out all the important points from the point of view of age, and also about microcephaly. Lot of informations have been there, and of course, he has considered the most important differential diagnosis. And the only thing, of course, clinical picture of the patient as well as this thing, no genetic study. If it is there, then we will be knowing what exactly. Probably later he can mention what was the final diagnosis after. I enjoyed. I learned a lot. Thank you so much.
Yes, sir. You are still in US, sir, or you came back?
Yeah, USA only, because I will be returning only in September end. 6 months green card. So I have to stay here for 5 years like that if you want to become a citizen. But my daughter is, I don't want to be here for 6 months. But unfortunately, my daughter has done that. Thank you so much. Okay.
Okay, sir.
Bye.
Okay.
I am a regular attender of your class.
Okay, shall we stop? Okay, good night, sir. Thank you. Thank you very, very much.
Good night, all of you. Yeah, good night.
Okay.
Thank you.
Thomas is there?
Thomas, sir, you want final comment? Thomas, sir.
Because he was the one who organized it. Okay, it's not. Okay. Thank you all.
Thank you.
Good night.
Good night. Okay, good night.